our express. Thank you. So good morning to everyone. Welcome to this new series of No Thrombosis Workshop series. Previously, my name is Dr. Ankush Gaikwad. I am heading medical affairs for SSD at MCure. We had a wonderful previous 10 series of No Thrombosis, and this is the 11th series today of No Thrombosis Workshop in Ischemic Stroke. So I welcome you all for this workshop. So stroke remains an area of high academic interest. If we see in 2022 alone, there were 10,000 publications on various search engines which mentions the word stroke. And out of these publications, there are nearly 500 clinical trials done across globally in area of stroke, which is a testimonial that stroke remains an area which is of high interest in various in the field of neurology. Now, beginning with our today's session, I'm honored to introduce our course director, Dr. K. Ashokan, sir. Sir is the Chief Neurologist and Head of Neuroscience Department at Sri Ramakrishna Hospital, Coimbatore, a life member of Indian Academy of Neurology and Neurology Society of India, an active member of American Academy of Neurology and member of Movement Disorder Society of India, President at Coimbatore Neurology Society, President at Tamil Nadu and Pondicherry Association of Neurologists. Sir has presented many papers in international and national conferences in stroke and epilepsy, conducted various international trials in neurology, and has special interest in stroke therapy. Welcome, sir. I'm pleased to introduce our two moderators for today, Dr. Roy. Dr. Roy is a Director, Stroke Program and Senior Consultant, Department of Neurology, Institute of Neurosciences, Kolkata. Sir is a certified neurosonologist, recipient of 2005 American Society of Neuroimaging William M. McKinney Award for the best manuscript on clinical research and neurosonology, executive member of Neurology Sonology Society of India, member of Educational Committee, Joint World Stroke Congress, Hyderabad. Sir has over 36 publications in various reputed and international journals, editor of various neurology books, and guest faculty at various prestigious national and international neurological meetings and conferences. Welcome, Roy, sir. Our next moderator is Dr. Agrawal. Dr. Agrawal is Director, Neurology, Stroke and Dementia at Max Super Specialty Hospital, Saket, New Delhi. Sir is a recipient of Health and Excellence Award in Neurology from Central Health Minister in 2016. Presented largest series of thrombolysis cases in stroke in India. Has received award for Best Platform Paper Presentation in IN 2002 and UP Neurocon. Published in reputed WHO's Who's in the World 2006 book, New Jersey, USA. Has received Best Young Teacher Award in 2003. Has contributed to many publications and chapters in peer-reviewed journals. Has delivered guest lectures in various parts of India, and expertise in stroke thrombolysis, neurocritical care, headache and Botox injection, epilepsy and epilepsy surgery, Parkinson's, and multiple sclerosis. Welcome, sir. I am pleased to welcome our two dynamic speakers for today. Our expert speaker for today is Dr. Kulkarni. Sir is a consultant neurologist at HSR Neuro Clinic and Columbia Hospital, Bangalore. Has more than 4 publications in multiple journals, attended multiple conferences and delivered talks on stroke awareness, migraine, headaches, smoking de-addictions, to name a few. Key skills include neurological disorders, headache, epilepsy, pediatric neurological conditions, demyelinating disorders, neuropsychiatric syndromes, to name a few. Welcome, sir. And our next speaker for today is Dr. Satish Kumar V. Sir is a senior consultant neurologist in charge of stroke program and stroke prevention clinic at Gleneagles Global Hospital, Chennai. Has received award for best neurosciences team by Confederation of Indian Industry CII TN Mediclave November 2002. Has also received Maruthua Viru Thugal Award for Best Neurology Center in Tamil Nadu in March 2022. Organizing member of Chennai Stroke Kaleidoscope and 9-minute stroke colloquy. Sir's area of expertise includes stroke and cerebrovascular cognitive disorders, epilepsy, including epilepsy surgery, to name a few. So with this, I hand over to Dr. Ashokan sir to take over the proceedings for the session and to start the session. Thank you.
Thank you, Dr. Gaikwad, for your kind introduction. First of all, good morning, all of you. I invite all of you for today's webinar. I thank every one of you for sparing time to participate in today's web meet. I thank Team MCure for arranging this web meet. This no thrombosis in acute ischemic stroke is going on every month since the last 2.5 years. As Dr. Gaikwad told, probably this is the 11th in the series. We had a very good and very useful case presentations from learned speakers across. We were fortunate to have healthy and meaningful discussions on cases and good interaction. And we learned many new things after these discussions. Hope you will also be benefited with more meetings, with these meetings and more meetings like this, and take it to bedside. Today, we have two eminent moderators and two excellent speakers with us, Dr. Satish Kumar and Dr. Advait Kulkarni. They'll be sharing their cases, interesting cases for discussion today with us. And Dr. Jayanta Rai sir and Dr. Puneet Agarwal will moderate the session. And first I call upon, without wasting time, call upon Dr. Satish Kumar to discuss his case. Dr. Satish?
Yes, sir. So good afternoon, everyone. So at the outset, I thank Ashokan sir, the MQ team, to give me an opportunity to speak about the stroke and thrombosis in this elite panel. And I welcome our moderators, Dr. Jayanta Rai Sai and Dr. Puneet Agarwal sir. So Puneet Agarwal sir is my teacher in my MD medicine. So welcome, sir. So we will shortly start off with hope my screen is visible.
Yeah, visible.
Yeah, okay. So I will be briefly sharing two important case vignettes which we've seen quite a few years back, and we learn from these cases because it's not so easy to manage these types of critical young strokes. So to start with, we all know that we manage strokes very well in acute time window, which is TPA. We give tenectase, we give endovascular therapy. But beyond stroke windows, there are certain drugs which got approved, but said that it's not only as simple of stroke management, putting them on aspirin or clopidogrel or statins. So this is a 33-year-old young gentleman. So he visits us on 25th of July 2021. He doesn't have any comorbidities except he had gout intermittently. He was taking medications and he was a smoker. So this happened around 11:45 p.m. in the night on a Saturday, while he was found to become unresponsive for a few minutes at the bathroom. So he had a sway while walking, and he also had a dysarthria. So he stays near to our hospital. So within next few minutes, he came to our hospital. So BP on emergency was 180/90. CT scan was done immediately within the 40 minutes after the within the next 10-12 minutes, it was reported as normal too. But he had a left hemianal ataxia on examination. He was considered to be having mild dysarthria. But more interesting finding was while he sits, he developed some form of drowsiness and some form of confusion. But while supine position becomes better. So this is called a head-up test, which was well studied in the head post trial, where fluctuating sensorium in a fluctuating blood pressure in a stroke means there is a large vessel. And his NHS score was 7 and aspects was normal because the CT scan was normal. So we decided to go for thrombolysis because he was within the window period with NHS of 7. So our door to needle time was 15 minutes. It was very early in the morning. and the window period from the onset of stroke symptom was 30 minutes. We used tenecteplase 12.5 milligram bolus. But since the CT scan was normal, he had a deficit. We haven't stopped there because we knew there is a possibility of large vessel thrombus. So we decided to go for MRI and MR angiogram because we want to know the where is the burden of stroke and which vessels are involved. So this was the MRI done. So which showed complete right ICA territory strokes. We can see also in the lateral PCA stroke. So we know there is a large vessel there. And this was an angiogram, MR angiogram initially, followed by a CT angiogram. So which showed that the right ICF is not visualized in the intracranial circulation, and from the CT angiogram confirms that from the origin of a common carotid, there is a complete cutoff. But we knew that the intracranial circulation is well formed from the time of onset of stroke. So we didn't bother worry too much about the burden of stroke and its comorbid. So yes, NHSS got improved to 4 after tenectase. But since there is a large vessel occlusion, we tried to go for a mechanical thrombectomy. It was around 1 a.m. on the morning on a Sunday, which we used a penumbra device to go for a thromboaspiration. Within the first pass, there was a successful recanalization. And this was decided because he had a IC occlusion, fluctuating blood pressure was the second indication, and third was a head-up test, which shows fluctuating GCS and NHSS. So these are all the indications. So this was the first angiogram which showed a clear-cut right common carotid thrombus. And this was after the thromboaspiration, the ICA was recanalized, but we can clearly see at the origin of right ICA, there was a 60 to 70% block, which we decided to go for stenting after the acute period. So post procedure, he continues to be stable without any fresh deficits. He was put on antiplatelets 150 milligram of ecosprin and rosuvastatin 20 milligram. And then we followed up with a transcranial Doppler at 9 a.m. on a Sunday, which showed a normal intracranial flow because we all knew that his intracranial flow was maintained from the beginning. He doesn't have any symptoms. So on a check carotid Doppler at 2 p.m. on the rounds, we found that the right carotid, which was recanalized by thromboaspiration, had a thrombus, and there is a complete occlusion of right ICA from the origin from the common carotid. So we decided that is this a possibility of reocclusion once the angiogram showed a opening up after thromboaspiration. But at this point of time, he doesn't have any new deficits, and there are no fluctuations even on blood pressure or sitting posture. And the BP maintains to be 150/90. So we decided, since we have done a thrombolysis, we did a mechanical thromboaspiration. The NHS was stable. Though there is a reocclusion, we didn't decided to go for any procedures on the same day. So next day on routine morning rounds at the stroke ICU, we found that his right femoral pulsation, through which where we did the puncture for the mechanical thromboaspiration, was thrombosed, and the right dorsalis pedis was not palpable. And we did a bedside arterial Doppler, which showed that the puncture site groin had a femoral thrombus with minimal partial filling of the dorsalis pedis. So he had one more occlusion, which is the right femoral thrombus. So this is a story where almost 36 hours after thrombolysis and thromboaspiration, he developed reocclusion of the vessel, though there was no hemodynamic strokes, and the puncture site also had a thrombus. So with the help of vascular surgeon, we decided to continue medical management by taking a anticoagulation of a low molecular weight enoxaparin. Next day, around 12:30 p.m., he developed one more minor left upper limb clumsiness and dysarthria, though he continues to be stable for 36 hours. And this time, to come to the background of the patient, he is a gentleman. Both parents are physicians and gynecologists, and the family has people who works in vascular surgery team, who works in neurosurgical team. So they have a lot of knowledge and insights about how to manage a stroke within the window period and within the first 1 week. So they asked us whether there is a possibility of opening up the vessel, which he had a new symptoms on the third day. So with their concurrence, though we don't have a clear-cut guidelines, we want to try a mechanical repeat thrombectomy. Also, not only for that, we also want to know how good and bad is the collateral flow in the intracranial circulation. Also, we want to know about the right femoral artery puncture site, whether it is risk of going for complete peripheral arterial ischemia ending up in gangrene and amputation. So this is the reason we have discussed, though we know that stroke re-exploration is not an option and guidelines. So whether there is a spontaneous progression of a major stroke or peri-procedural stroke risk, all those things were discussed. So the repeat thromboaspiration was tried on the third day through the left femoral route because the right femoral route was already thrombosed. And this time we found that there was no recanalization, there was no ICA we could able to open despite two tried attempts to open with thromboaspiration. So, but to our surprise, we knew that the right MCA are very well filled, and we had a very good intracranial circulation through left MCA and ACA and ACOM. Not only that, the right posterior communicant artery was very well opened up without showing any significant flow limitation. So the collateral score was grade 4, which was very good for the intracranial circulation. And the right femoral artery showed a right femoral and iliac vessel thrombosis, but this again, so nature's God's gift that the profunda femoris and the circumflex femoral arteries were opened up to perfuse the popliteal flow, though there was a delayed slow flow. And we try to do aspiration of the femoral thrombus, which results in almost near recanalization of the femoral artery, and the popliteal connection was maintained. So the second attempt was intracranially, we couldn't be able to manage well because there was a complete recanalization is not possible, but the femoral recanalization was attempted in the second intervention. The story doesn't end there. Next day, this was on 29th, we found his left femoral artery puncture site also has a mild thrombus, though the patient was continued on anticoagulation on a prophylactic therapeutic dose. And again, a check arterial Doppler showed no flow limiting occlusion. So this was the angiogram. The intracranial angiogram showed a complete right ICA thrombus. The intracranial circulation was well formed. And we want to know about the recurrent stroke risk, why there is a risk of thrombus in the peripheral as well as intracranial circulation and other things. So, we did a stroke in young workup, the APLA workup, the Bush-Blackish workup, the procoagulant. Just a minute. So the procoagulant workup, we found that he had a low B12 54, the folic acids were low, the homocysteine was more than 50, and he had a heterogeneous mutation of methyl tetrahydrofolate reductase hyperhomocysteinemia gene. So putting together stroke risk, he was a gout patient, he was a smoker, he had a old DVT and hyperhomocysteinemia along with folate and B12 deficiency with a genetic defect of homocysteinemia. So there is a risk of thrombosis in this patient called hyperhomocysteinemia. Though the guideline says adding on B complex doesn't give much therapeutic yield for management. So this was the story we learned from the patient. 3 months follow-up. Luckily, though there is no ICA opening up, but the intracranial flow is well maintained. The clinical stroke scales were near normal, and we had more than 12 months follow-up now. And this is the current CT scan showing the same ICA occlusion with good intracranial flow through cross-collateralization. And this is the patient, both the sides, including the peripheral, both legs were normal now. So the take-home lessons from this patient is, though we did a very fantastic job on a early Sunday morning, do not celebrate too early because we have to decide what is best for the patient, because we knew that though we have done everything for the patient, we couldn't be able to recanalize the right intracranial circulation. Said that recanalization is not directly proportional to the stroke outcome in every cases, because thinking in mind what is the hemodynamics, what is the collateral circulation, and what is the risk factor underlying all these interventions. And it's very difficult to communicate and make a clinical decision making in these types of patients who are well connected with understanding about the pathophysiology mechanisms, because they are well connected with a doctor's network, is very important, because the team is more important in taking decision making in very tough and failing cases. We have to think out of the box for a rare presentation, and then we know that the stroke in young is not so easy, though it is not dissection, though it is not vasculitis. Sometimes a genetic defect and coexistent risk factors can add on to the risk. And as primum non nocere, do not harm to the patient, because multiple attempts can be a futile attempt and can be detrimental to the patient. So our aim is to maintain the benefit to the patient, do not harm the patient. And wait and watch if the cerebral flow and hemodynamics are well made. So this is a story we learned with multiple thrombosis on acute stroke in a young stroke with IC occlusion. Coming to the second case, this again is a stroke conundrum to us. This is an in-hospital stroke in the era of Chinese brain. This again a 35-year-old male who brought to an emergency with history of drowning in the beach near Pondicherry during the festival time on 13th of January 2019. He was very young and he had an alcohol intake and he drowned in the seashore. Initially, he went to a Chengalpattu GH where he was intubated and resuscitated high fluids and shifted to the our center through an ambulance. This person does not have any other risk factors apart from smoking and alcohol. So he had ARDS due to drowning, and this is the CT X-ray. So for that, they did a complete screening of the CT brain because he was unconscious. This was on the day of admission to the emergency in our hospital. CT scan was normal at that time, and he was put on ventilator, sedated, and paralyzed for the next 2 days for ARDS protocol. And 3 days after the onset of drowning, when they weaned off from the ventilator and weaned off from the sedation, they found that he has noticed to have left-sided weakness. And then the urgent neurology opinion was obtained. And when we went there, and there he appears a little confused, there was less speech output, seems to become aphasic, though he understands and comprehends our commands. And the last seen normal was not known because he was on a sedation for 3 days. Neurological examination, he was drowsy, aphasic. GCS was E2, VT, he was intubated, M5 on the right side, so he had a left-sided hemiplegia. Pupils a little, asymmetrical. The right was 4 and the left was 2. The total NHS stroke scale at the medical ICU was 16. Blood pressure was okay, and pulse rate he had a bradycardia. So we asked for an urgent MRI, and then it was the MRI which showed a large right cerebral artery thrombosis. The gross malignant edema with a midline shift. So this was the condition. So this stroke might have happened during the hospital visit. We don't know whether it happened during the drowning time. Though the initial CT scan was normal, sometimes CT scan can be a normal in a large MCH stroke. So this is an in-hospital stroke, but we don't know when was the last seen normal. We couldn't proceed further. And we did an angiogram which showed that the right common carotid or right intracranial ICA was not seen. Though we can clearly see here that the PCOM was dominant. So that was some good news. So how do we proceed further? Should we take a chance of thrombolysis in this case, whether we go for a thromboaspiration on day 3 or day 4 of stroke? We don't know the exact stroke onset time in this patient. Let us leave him. Since he is young, we'll do conservative measures, or we go for a decompressive hemicranial. So these are the dilemmas in mind, and we all knew that as per the guidelines, he is young and this is a large stroke on day 3, and NHSS and a fluctuating drop in the sensorium in next 4 hours, and this is the check CT scan which showed a more increasing infarct, so we decided to go for a decompressive hemicranial. And as per the guidelines, younger age, severe infarct of NHSS more than 15, a fall in GCS score of 1, or the fall in NHSS score in the alertness score of 1, the CT more than 50% of a middle cerebral artery infarct volume of more than 145 centimeter within the first 48 hours of after the onset of stroke symptom is an indication for decompressive hemicranial. And then we want to know about the mechanism of stroke because why he has developed at this point of time. So we did a CT angiogram, which we found the right ICA starting from the common carotid artery was not seen. And there was a thin tapering of intracranial circulation. So then at the source image, we could see that the right common carotid artery has a thrombus with a possible dissection within the common carotid artery. So the point here is this dissection is not in the cervical portion of intracranial carotid. This is in the common carotid. So common carotid artery dissections are very rare. So far, up to 2022, we have only 46 case reports, and out of them, more than 30 were due to trauma, blunt trauma, injury, polytrauma. So we don't have, though this patient has a drowning, we never knew what is the mechanism of stroke. And so we encountered in the medical ICU whether there any chance that central lines or arterial lines were poked in the neck, and that was not also the scenario. So we don't know whether why he developed a common carotid artery dissection. And then, as per the dissections, initially we used to give anticoagulation, but now the evidence says that antiplatelets are as equally non-inferior to anticoagulations in dissection. And this is what we managed him from 2019, and he became better, and he followed up with us, no major outcome. So if you remember the history, he had an aphasia. So he had a right MCA stroke and he had a left hemiplegia with an aphasia. And he continued to have that up to 6 to 9 months after the stroke. Though his comprehension is not completely normal, his word output is there. So it's not a classical Broca's aphasia. Then we gone through our literatures. Is there? He is not having. He is not a left-hander, or he does not have a crossed hemiplegia or something. So, though we didn't know about his aphasia is common on right hemispheric damage, there are very case reports, and here they found that the auditory sentence to picture naming defects are more common after right hemispheric strokes. We all knew about prosopagnosia, anosognosia, as well as loss of prosodia of speech. All those things are common in language after stroke, like a pragmatic disorder. But this man has an aphasia after right hemispheric stroke. And the take-home messages here is identifying in-hospital stroke is still a challenge if the patient is on sedation and ventilator after the medical complications. Not all post-decompressive hemicraniectomy patients have a poor outcome with a large MCA or ICA stroke. And common carotid artery dissection in this case is a very rare sight. We didn't knew the classical mechanism of dissection in this case. And aphasia is not always crossed. Sometimes right MCA stroke related language disturbances are present, though not very common. So I end here telling that in these cryptogenic strokes, to be very careful in finding out the mechanism of stroke, because that's why you can prevent a further stroke. So your eyes can't see what your mind doesn't think, and everything is cryptogenic. 40% of strokes are cryptogenic in this era of acute stroke teamwork. So until you see it, until you search for it, until you hunt for it, you don't know the cause of stroke and how can you prevent it. Thank you.
Thank you, Dr. Satish Kumar, for your excellent two cases. Really complicated and very well managed. Just start of the discussion and we'll go with the moderators. First thing I'd like to say, your first case,
Yes, sir.
probably the hypercoagulable state, isn't it?
Yes, sir.
So thrombus everywhere, tends to occur everywhere. So hypercoagulable state. And thing is, the first MR angio showed there seemed to be some cross circulation, and opposite MCA is getting filled and going to the periphery. Normally what we do, of course, we thrombolize, and if no further clinical deficits, probably wait and work up for the stroke mechanism, what are caused. But if the patient deteriorates meanwhile, if there is new deficit, no doubt, if it is within 24 hours, you have to go ahead with the thrombectomy and look for it. So that's my first thing. As correctly told by you, the thrombus on the right femoral, thrombus on the left femoral, isn't it? And following the injection, so thrombogenic mechanism of stroke. And only thing is what cross circulation already occurred and is stable otherwise. So probably after thrombolysis, you would have waited for a stroke mechanism until you get the deficits. That's my first thing. Second thing, your second case very, very interesting. The dissection at common carotid. Yeah, that's very rare. That's very rare. And as you told correctly, if it's a large infarct, more than 2/3, almost the whole of the MCA, malignant infarct, midline shift, already there is cortical, extensive cortical involvement. There's no point doing thrombectomy. And already 3 days over, there's another point. We can't do after 3 days. But more than that, the infarct itself, the size of the infarct itself, even it is within the window period of 24 hours, what it may be, I think you could not have proceeded with thrombectomy, and you would have done only mechanical, decompression. That's correct. And yes, young people, decompression, recovery rate is good. Yeah, after all, it's life-saving, first of all. And with physiotherapy, because we have seen quite a number of cases, the young people like this, they recover very well. Maybe it might take 5-6 months. That's it. There again, that's what the internal carotid, everything disappeared because of the dissection of the common carotid itself. Could you think that's what manipulation, etc. we see in internal carotid, not in common carotid. Hyper stretching of the neck,
Yes,
manipulation. Or did you search drowning anyway causes this dissection? Drowning,
No.
any pressure increase? Pressure?
The case reports of 46 cases never mentioned about drowning. The majority of the cases are polytrauma due to road traffic accidents or some, stab injuries, sharp instruments, chiropractic manipulation and other things. So that's why we went back to our medical ICU team whether they have done any, there is a chance of poking in the neck by doing, arterial puncture and other things. So they too denied that. So that means we are not sure about the mechanism of common carotid artery thrombosis in that case. So it's quite interesting. So that's why we choose to present the case.
Yeah, very interesting. Thank you. Then I invite Professor Jayanta Rai.
Yeah, thank you, sir. Satish, first of all, good to see you after a long time.
Yes, sir.
Hope all is well.
Yes,
And
all is well,
very
sir.
interesting cases, especially your first case.
Yes, sir.
And also, sir has raised some pertinent questions and points. So is it possible to show us a couple of first 2 slides of your presentation once again?
Okay, just a minute.
If you can put it up.
Yes, sir.
Yeah. Meanwhile, I have a question because anyways, moderators will be giving the comments.
Yeah, please go ahead.
Satish, while you are showing the angio,
The next one?
whenever there is a non-visualization of ICA, the question comes whether it is chronic or acute. So,
Okay, so
how do you know whether it is chronic or acute in this case?
true. So coming to the same point where we are discussing about, we did a thrombolysis because we did thrombolysis with CT scan. So we knew that he had a stroke because he had a deficit of NHS of 7. And the 2 important factors which makes us to think about thrombectomy in this case is a fluctuating sensorium. So this man, though the MRI showed a very tiny punctate, non-disabling like a lacunar infarct showering in the ICA territory in the lateral PCA. You can see here in the first slide. So the vessels, you can see this is everywhere in the MCA, in the lateral PCA. We so know that it's on the right side on the ICA circulation. And the MRI itself has showed the right ICA is not seen, and he has a very good intracranial cross circulation through the left side, filling from almost the complete MCA is filled. So why do we need to intervene is the question. The question is, as per the evidence, the large vessel thrombosis, if it is acute or chronic, is the question number 1. The question is whether to intervene or not. Here, the factors which say he has to intervene is the head-up test, which is the 4th attempt we ask him to sit. He becomes drowsy and there is a deficit. So from NHS of on lying down, the NHS after thrombolysis from 2 he became 7. So he had a hemiataxia and he became drowsy, he couldn't be able to speak. But while lying down, he wakes up. So there is a hemodynamic stroke there is a hypoperfusion on sitting, and the blood pressure shoots up on sitting posture. So these are all the clear evidence to say that, see, there are indications for mechanical thrombectomy even in a transient ischemic attack in a large vessel circulation, if you prove that the head-up test and the fluctuating blood pressure. So these are all special extra indications for mechanical thrombectomy when there is a large vessel occlusion, though the volume of stroke is less, though the intracranial circulation is maintained. But yes, there is a risk of inducing bleed, inducing a major stroke during the procedure. That is well seen. And coming to the point whether he has an acute or chronic thrombosis, it is acute because we seen that there was a opening up with a Penumbra device. We didn't do any intracranial solitaire or angioplasty or anything. So it opened up completely from the ICA up to there. And it's a nature's God's gift. If there is occluded, intracranial circulation is formed from the opposite side. And when we shooted the right common carotid, right ICA from the origin, there was a 70% block in the origin of ICA, which indicates there is a atherosclerotic component in that. And then right ICA is completely recanalized after aspiration, and even right MCA is formed through the right ICA. So that means it is an acute event. It was not a old event. So suppose if it is a chronic long segment occlusion, then right ICA will not open up on thromboaspiration, and the right MCA will not be filled through the right ICA shooting of the dye. So these are all the points we diagnosed after the angio of the DSA, that he had an acute thrombus and we opened it. But fortunately, he had a
Satish,
reocclusion.
sorry to interrupt you. What I was trying to tell with these two slides, the previous one, where you showed the DWI restrictions in the right hemisphere, and then the angio. I think that the large vessel occlusion is at the common carotid level.
Common carotid. Yes,
now, if we look at the stroke mechanism, there's multiple DWI restrictions are due to embolic phenomena. So had it been a hemodynamic stroke at this point of time, we expected a larger clinical deficit. So patient probably having a embolic event at this point of time. And secondly, since there is a very good cross flow, and M1 MCA was feeling very nicely from the other side. So my question is, in case of mechanical thrombectomy, when we target the terminal ICA or proximal MCA, sometimes proximal ACA, some cases, I'm talking about anterior circulations. Here, none of these vessels are actually occluded. Rather, in your subsequent angio, it has shown that the cross filling is actually filling the terminal ICA very well retrogradely. So this part is completely open. Now, my question to you is, and if you get a second chance to treat similar kind of cases in future, would you again go for mechanical thrombectomy in this patient? Up to IVTPA is definitely indicated. The patient came with acute stroke and patient had some deficit. But question of, does mechanical thrombectomy will prevent a further stroke in this kind of situations? Because it also runs a risk of clot dislodgement and going into MCA, M1, when we can get another new stroke. So maintaining a hemodynamic and giving them antiplatelet at an appropriate time, whether that is more beneficial and safer than trying a mechanical thrombectomy at the proximal CCA level, because these are definitely off-label cases.
True.
Do not know what is the
I will completely agree with you. Even in the same clinical case, we haven't decided to go for mechanical thrombectomy at that early hours on Sunday. But as I told you, in this case, it's though we found that the PCOM is dominant and the MTS are also filled from the left ACOM and ACA. So on doing the check angiogram, we decided to go only with the check angiogram. So the check angiogram showed that there was a carotid block of 70%, and then initially the ICAs are not filled, and then the left ICA, the MCS were filled through PCOM and ACOM. And then the decision here is on table on the cath lab. We decided the same thing. We checked the blood pressure variations, clinical deficit. So whenever he sits up, his left upper limb and lower limb becomes ataxic and weak. And whenever he lies down, he becomes conscious, alert, and also. So we know that there is definitely hemodynamic stroke due to common carotid occlusion. And believing that, we don't know whether the next day he developed a complete MCA stroke or ICA stroke. We are not sure about that. Though we have discussed that doing a procedure may harm him, but we try doing an aspiration, saying the two factors of fluctuating blood pressure, fluctuating sensorium, and postural variation of deficit. So these are all the extra indications to decide on thrombectomy in the window period of 24 hours.
True. And another way of looking at it is probably if we go conservative, and some people even tried anticoagulation, short-term anticoagulation in these patients to prevent further embolizations and watch them closely. And if the patient develops another M1, say M1 occlusion later on, that can be taken as a fresh event. And you have option to go for mechanical in those cases. So I think debate will continue, but I think we should move to the next case.
Yes, sir.
Yes.
And your second case was pretty straightforward. But I think in hindsight, we do not know whether the patient had a stroke, then he drowned, and then he was taken to the nearest hospital in a very bad condition, intubated, maybe sedated, then transferred to your hospital. So at 5 a.m. in the morning, what he was doing in the water, I don't know. How, what is the background? But I have seen two CCA dissection cases. One was attempted hanging, and another was a trauma. So CCA dissection is not a very common thing. Most of the cases we find some antecedent cause behind it. So I do not know what was the background in this patient, but it is possible that he had a stroke and that's why he drowned. Then
This
went
is,
through all this
Maybe
resuscitation procedure.
strangulation also maybe.
possible.
Yes. So we don't know. So then hemicraniectomy is probably your only option.
True,
But
sir.
there was no other way to do it.
This is
Anyway.
the aspect scoring after 5 hours after the onset of stroke. So might be a chance he had developed stroke while drowning. Some signs should pick up in the CT scan.
So this is
Luckily
5
that
hours after.
5 hours after 5 a.m. This is 10:29 in our hospital.
Yeah, yes, this one looks so far pretty good.
Yes, sir.
So do not know whether the dissection was there and that grown and the
Slowly,
stroke happened
slowly,
even
slowly.
thereafter. It's not
So
that
we don't know the
dissection
onset of
happens
stroke in this case.
in the first go. Anyway, interesting case. So can we go to the next case because we're running out of time?
Thank
Yeah,
you. Thank you,
I
sir.
just want to make one comment. Hello.
Yes,
Yeah.
Dr. Agarwal.
Puneet.
Yeah, hi. So I just want to make, I think it's interesting. Dr. Satish, you have done a wonderful job. I think you have presented a very interesting cases. I just one or two small comments. I think Rao has rightly said that seeing just looking for the first case and patient who is it's really very interesting case, having a thrombosis everywhere, even after in various places, and having hyperhomocystinemia, a lot of risk factors, smoking, dyslipidemia, which may be the culprit of hypercoagulable state, although and your homocysteine level is more than 50, which qualifies for the moderate to severe type of hyperhomocystinemia. So, I agree that the patient had a TIA type of episode one day before that also, according to your slides. So possibilities are very high that patient is having some thrombus sitting there in the right IC on the top of the stenosis, which is 60 to 70% the right ICA, and leading to emboli and having a TIA one day before and later on a stroke. So I think when you have shown the DSA, which is showing possibility of thrombus also in that area, which may be controversial, but possibilities are there. So I think my point is that I think that doing the mechanical thrombectomy is definitely one of the, although it's debatable, but is one of the option which we have taken rightly at that point of time. And this completely recanalized. After that, you have there is a recanalization also has happened. So so I think that's a right step you have taken at that time. The only thing is that after the have you tried the anticoagulation after that or not?
The first one day, first 18 hours, we didn't do anything, sir. But once we knew that there was a reocclusion, but the imaging MRI was pretty the same, so we didn't try anticoagulation. we started anticoagulation the next day when we found that the peripheral arteries are blocked. So initially did heparin, but we also give ticagrelor in this patient, which I haven't mentioned. It was on day 4th when we found he had continues to have symptoms of left-sided hemiataxia, fluctuating sensorium, and even on day 4 of stroke. So, and as I told you in the background, a lot of inputs from other doctors' family. So it's very difficult to take one by one clinical decision making in every time when he fluctuates with stroke in you.
So any long-term anticoagulation did you use after
No,
that?
we stopped. We gave anticoagulation for 6 weeks. After that, he's only on antiplatelets.
Okay, and second is that because patient was having IC stenosis around 60 to 70%. So did you go for the later on any stenting in this patient?
No, we didn't do, sir. We didn't do.
You're not gone.
Because second time we had a re-exploration in DSA on day 3. So that time our plan is not for aspiration. Our plan is to try to open up with the help of stenting. But that time we tried negotiating stenting devices, but we couldn't.
Yeah. Just a brief comment on the second case, because it's a really interesting case, drowning with the associated with the ICA dissection. I have 2 cases of CCA dissection, but I think in this case, patient maybe possibilities are there, maybe having a stroke. That may be one of the reasons for the at the time of drowning. That is one of the thing, and maybe leading to drowning due to the stroke also. So I think besides the trauma, I have seen that sometimes the long transverse process of the cervical vertebra. I have 2 patients of like this leading to dissection due to the hyperextension of the neck due to any reason. So that is a one postulated mechanism which may be one of the culprit in your case also. I don't know whether you have looked for the long transverse process of the cervical vertebra and in this case or not.
Our CT angiogram neck doesn't reveal that, and though he is a very tall, thin person, and he has a long neck too, so there may be a possibility of drowning induced some dissection there, and he developed after our CT scan, after our admission, developed thrombus and gone into the MCA. That is a possibility always there.
Yeah. Thanks for Dr. Satish. Very interesting cases.
Thank you, sir. Thank you.
Thank you, all of you. So we had very good discussion. And the next we'll go on to the next session, next presenter. I call upon Dr. Kulkarni for his case presentation. Dr. Kulkarni.
Yeah, thank you everybody for this wonderful opportunity to share the stage with all of you. It's a privilege to be here. So I'm going to present a 40-year-old gentleman who came with the complaints of imbalance while walking and blurring of vision. He was apparently all right 60 minutes back when he noticed blurring of vision. He also noticed double vision while looking up and down. This was associated with imbalance while walking. There was no history of headache, no weakness of limbs or any tingling or numbness, no previous history of diabetes, hypertension, no addictions, smoking, alcohol. A general examination was normal. BP was 140/90. Higher mental functions were normal. Pupils were mid-dilated, reacting sluggishly to light. In eye movements, horizontal saccades and pursuits were normal, but vertical movements were restricted. Rest of the cranial nerves were normal. Power in all the limbs was normal. Gait ataxia was noted, and there was right finger nose incoordination. So in his case, NIHSS was only 2, that is one for ataxia and one for gaze. And I would like to show his eye movement video. So, see, the horizontal movements are normal, but the vertical gaze is completely impaired.
It is a little hard for me to take it out.
Even the downward gaze is impaired. So it's basically a vertical gaze palsy.
Left, right is okay.
Down.
Down भी मुश्किल है.
Left, right, you can see.
But laterally?
Lateral is okay. Lateral seems okay.
Okay. Okay, don't blink.
So stroke code was activated as he was in window period. However, MRI brain done, which was normal. Initial MRI showed no infarct. So initially, as we know, in posterior circulation stroke, small infarcts may not be seen. However, due to strong clinical suspicion, we asked for a B2000 diffusion MRI images, and it showed infarct in the midbrain. So usually the diffusion normally we use B1000 grade. However, in special cases, we can use B2000 intensity of diffusion weighted images, which can show smaller infarcts, which can be missed routinely. And we decided to thrombolize the patient as he was in the window period. Door to needle time was 60 minutes. And in next 24 hours, his balance improved, vision also was better. And 48 hours after thrombolysis, there was no deficits. So coming to some anatomy and physiology, we know that the vertical gaze is mainly initiated by the rostral interstitial nucleus of MLF, that is the gaze initiation center, and the interstitial nucleus of Cajal is the gaze holding center. So the pathway of the brainstem for the vertical saccades involve the parapontine reticular formation, the rostral interstitial nucleus of MLF, the nucleus of Cajal, and the nuclei of the cranial nerves 3 and 4. For upgaze projections from the rostral interstitial nucleus of MLF traverse to the posterior commissure, whereas there are direct downward projections from RI MLF to the cranial nerve 3 and 4. So in this case, we can see that it was mainly affecting the upgaze centers in the MRI. So coming to MRI and posterior circulation stroke, as we have seen in this case, diffusion images which are acquired with a value of 2000 seconds per mm were better than routine diffusion weighted images acquired with a B value of 1000 for the detection and estimation of the extent of diffusion change in patients examined within 6 hours of ischemic stroke. And these images do not take a whole lot of time. The MRI imaging with diffusion weighted images misses 15 to 20% of posterior fossa infarctions in first 24 hours. So MRI diffusion weighted has maximum sensitivity for brainstem stroke at 70 to 100 hours after infarction. If the physical examination suggests that diagnosis is stroke, do not use a negative MRI result to exclude diagnosis. Another point which I want to say is NIHSS and posterior circulation stroke. In this case, as we saw, the NIHSS score was only 2. Still, we took a decision to thrombolize because it was a disabling stroke. It was affecting his vision, the gaze, and also balance. The severity of posterior circulation stroke can be undermined by NIHSS as it is more skewed towards anterior circulation related cortical findings. Diplopia, gait and balance disturbance, dysphagia, vertigo are not graded by NIHSS. Conversely, cortical symptoms such as aphasia and neglect have a prominent place in NIHSS while being more common in anterior circulation strokes. Safety and outcome of IV thrombolysis in posterior versus anterior circulation stroke results from a safe implementation of treatments in stroke registry and meta-analysis. So it has been shown that the IV thrombolysis in posterior circulation stroke is associated with half the risk of parenchymal hemorrhage compared to IV alteplase in anterior circulation strokes. And there was a lower median NIHS in the posterior circulation group, that is 7 versus 13. This is because diplopia, gait and balance disturbances, dysphagia and vertigo are not graded by NIHSS. So the conclusion is posterior circulation strokes count for approximately 20% of strokes. Asking probing questions are a key to differentiating vertigo and posterior circulation stroke. Posterior circulation stroke is associated with some interesting syndromes, and IV thrombolytic therapy may be appropriate if eligible. Thank you.
Thank you, Dr. Kulkarni, for your nice case. And 2-3 things. Thing is, as you said correctly, this posterior circulation strokes may be missed in MRI first 12 hours at least, if not 24 hours. That's why if you are strongly, clinically, if you doubt posterior circulation stroke, always ask for B2000. You need not wait for the outcome results, straight away, if you suspect posterior circulating strokes, you can straight away ask for B2000. Otherwise, if you have the facility, 3 Tesla easily reveals these infarcts in the early phase, better than 1.5 Tesla. And third thing, when we do all these things, we do ask for MRA also. So hope MRA normal, isn't it? Best
Yes, yes, MRI was normal, yes.
Normal, MRA. So we look for that also. And of course, as you said, we don't go by NIHS for this disabling deficits like vision, such an important thing. And as you said, vertigo and all those things. Yeah, we do thrombolyze. And thing is, outcome is going to be good. So as a routine, if you suspect posterior stroke, as a routine, we can ask for B2000. You need not wait for the report and ask again. That's common. Otherwise, very good cases.
Yes.
Professor Jayanta Roy?
Yeah, yes, sir. I think, yeah, first of all, very nice case and good neuroanatomical exercise once again with this.
Thank you, sir.
And as you rightly mentioned, yes, higher B value, especially you should also ask for a coronal DWI, especially for medullary strokes. Sometimes a small medullary stroke, even in axial cuts or DWI, there are some artifacts. So coronal DWI has got a better visualization of small posterior circulation strokes at the lower brainstem level. So at the same time, higher B value with a coronal cut give you a better visualization. Otherwise, it's a nice case as we discussed. Thank you, Dr. Agarwal.
Thank you, Dr. Roy. Dr. Puneet, your comments, please.
Yeah, so Dr. Kulkarni, really a nice case you have presented. I think I agree with all the comments which mentioned that posterior circulation stroke is very commonly missed even in MRI in initial hours, and rightly pointed out 2000 is a good technique. In fact, we are having 3 Tesla MRI here. So we have used, as you rightly said, Dr. Ashokan, that 3 Tesla can detect better and then 1.5 Tesla. And we have gone for the 3000 diffusion sequence also. So 2000 or 3000 sequence, although they have many times, they have significant false positivity also. We have to be cautious. We have to correlate with the clinical picture, but they are the very sensitive parameter to pick up the stroke if we are clinically confirmed that patient is having a stroke. So for the verification, 2000 or 3000 sequences are better. And as you've rightly done, the thrombolysis should be done because of the disabling stroke. And I think the site location is in the midbrain. Most likely it is from the penetrating vessels of either the PCA, which may be the one, the bilateral PCA, that may be one of the culprit of this kind of a stroke. Mostly, usually they are atherosclerotic in origin. So it's a nice case. Thank you.
Thank you. Thank you, Dr. Puneet. Dr. Satish, any
sir.
comments?
I think it's a very interesting case, and we completely agree. Every one of us seen a normal MRI, and NHS has always been difficult in all posterior circulation strokes. So for this point, there is 2 scores which for posterior circulation we commonly apply. If you think it is a posterior circulation stroke scale, we have to add on with there is a posterior NHS stroke scale where we have to give gait and balance, dysphagia, as well as one more, I think, cough reflex, and there are some scores. So if we add on that, score will definitely cross more than 8, and then there is an indication for thrombolysis and thrombectomy in posterior circulation strokes. And there is an old stroke scale called Adams stroke scale for posterior circulation stroke scale, which is not under any clinical trials nowadays. So posterior NHS stroke scale is a separate scale. The other point is there is one diffusion techniques called focus diffusion. So even in a 3 Tesla MRI in midbrain and medullary infarcts, we may even miss out even 70-40 after stroke also. So we have a case where a bibrachial acute syndrome, we thought of cervical spine, we thought of and on the second MRI we did that also was reported as normal, and then we discussed with the radiologists, and they asked to go for a focused diffusion weighted imaging with it's literally it's a zoom cut where they see posterior fossa in a better way, which is called a focused diffusion, which can pick up a small acute thrombus. So these are all the clinical points we can use it for posterior circulation.
Thank you, Dr. Satish. I think we have come to the end of the session. We had really very good discussion. I should thank both the moderators and both the speakers for their excellent disposition. Winding up, any comments from any of you? Otherwise, we'll wind up. We'll go to the host for the vote of thanks. So, host, Dr. Kekwar.
Yeah, thank you, sir. First of all, I would like to thank our speakers, Dr. Kulkarni and Dr. Satish, for presenting very nice cases, and also our faculty for today, Dr. Agrawal, Dr. Roy, and Dr. Ashokal sir, for giving their expert comments and suggestions on this case. So thank you so much for the exciting and fruitful discussion for today. I hope it was very useful for the participants who joined this workshop and webinar, and they have gained significant knowledge from this case sharing from the speakers and the expert comments from our faculty members. So thank you so much for joining this Sunday morning on this no thrombosis workshop. And from Team MCure, I would like to give a thank you for all the faculty members, speakers, and all the participants. So thank you so much.
Thank you,
Thank
all.
you, everyone.
Thank
Have a
you.
good
Thank you, everyone.
Thank you. Bye.
Thank you.
Enjoy the World Cup.
Have a nice day.
Thank you, sir.
Bye.
Sir.
Recording stopped.